Numbers are still rising, but I think we need to make a start. Is everybody happy with that?
Yeah.
Ready to go, Emily?
Yeah.
Okay. Right, great. Well, a huge welcome today to so many people on to this Mid-Not CVS Alliance Diabetes Prevention and Awareness event. You're all incredibly welcome. Thank you very much. A little bit of housekeeping before we start. The event is going to be recorded. So if you aren't happy about having your face seen on camera, can you turn your camera off? And then we won't know that you're there. Just so that you know, we've placed everybody on mute because really I'm afraid we've got an absolutely jam-packed event, and so I can't, we haven't got time for questions throughout the presentations, but there will be an opportunity for questions at the end. So I would like to ask you to put those questions in the chat box. I'm going to indicate where the chat box is. Down at the bottom, for those of you that don't know, the chat box is on the toolbar at the bottom, and we have some rather nice technical fairies in the background who are going to be picking up those questions so that we can see them at the end. So I'm ready to kick off today's agenda, which is quite packed. We've got a lot of experts waiting in the wings, the first of whom I'm very happy, it gives me great pleasure to introduce Diane Smith, the Improving Care Manager for the East Midlands Diabetes UK, who's going to set the scene for us.
Hello, everybody. Really nice to be here. As I say, I'm Diane Smith, Improving Care Manager for Diabetes UK. Can I have the next slide, please? Okay, so I'm going to try my best to set the scene today in terms of talking about the big picture and what the facts are about our diabetes crisis. I'm going to show a short video for you, which is going to tell you all about diabetes. And we're going to have a little bit of discussion around sort of why diabetes is serious, what the signs and symptoms are very briefly, and then just a little bit about how Diabetes UK can help. Next slide, please. Okay, so the reality is that diabetes is affecting more people than ever before. It is really currently our biggest health challenge for the UK and in fact globally. As you can see, there are over 4.6 million people currently living with diabetes in the UK, and that is estimated to rise to 5.3 million by 2025. So we know it's something that's very much on the increase. As you can see there, there's almost 4 million people that have a diagnosis in the UK. But what that really also tells us is that there's almost 1 million people then who are undiagnosed. And this means that although they are undiagnosed, they may also not even know that they have the condition. So we really do currently have a diabetes crisis. And you know, the staggering figure is that we know that diabetes is on the increase. And it is in the last 12 months and in the last year, it has increased by 100,000, and it's doing so each year. This is putting enormous pressure on our NHS and our care systems. Have the next slide, please. Okay, so we really, you know, what is the reality of diabetes? Well, you know, did you know that 700 people are actually diagnosed every day? Well, what does that equate to? We've talked about some enormous figures there, but what does that actually mean? Well, it actually means that one person is diagnosed every 2 minutes, and that kind of really sort of gives you a clear picture of the importance of our diabetes crisis and that we need to do something about it. Next slide, please. Okay, so we've talked about people being diagnosed with diabetes, but we also know that there is a period of time before somebody actually gets their diagnosis that we know that they're in a pre-diabetes state. And what does that mean? Well, it simply means that the blood sugar in your body is higher, and it's higher than it should be normally. But it's not quite high enough to actually be diagnosed with what we consider as type 2 diabetes. But the important thing is we know 3 out of 5 cases can be avoided. And this is simply done by managing your weight, eating healthily and balanced diet, and being more active. So although we know that there's a lot of people, a huge number of people that are being diagnosed with type 2 diabetes, what we want to be able to do is to capture people in this pre-diabetes situation before it's too late. Move on, please. We also know that some people may be at a higher risk of developing diabetes. Certainly we know that if diabetes is in the family, somebody may have an increased risk of developing diabetes. We know that it's also related to what we consider risk factors, and that can be weight, it can be the fact that you smoke, it can be lifestyle, it can be age, and these are all what we class as risk factors. The important thing is that we now know there is 12.3 million people in the UK that are at an increased risk of type 2 diabetes. And that is a staggering figure. And so we do need to do something about that. Next slide, please. Next slide, please.
Got a bit of a blip here. It doesn't want to move on.
Bear with us. Okay, so there are two types of diabetes. There's type 1 diabetes and type 2 diabetes. And as you can see here, we've put them into two little bottles to try and sort of explain very clearly here the proportion of type 1 and type 2. So of those 4.6 million people, only 10% of that figure are diagnosed with type 1. The huge number is not, the 90% there is people that have type 2 diabetes. And so that's really an area that we really need to start to focus on, and we need to take note of. And it's people being developed with type 2 that we really want to, sort of support and get in touch with so that we can prevent it. Okay, so as I mentioned, the NHS figure around supporting and dealing with diabetes is enormous. And it's actually 10 billion a year. And I'm not sure if you know what that necessarily equates to, but certainly it is 10% of the NHS budget. And that's the entire NHS budget. And we know that this isn't necessarily just on diabetes medication, it's actually related to the complications of diabetes. So people having to enter into hospitals for operations, for renal therapy and all those sorts of things. That's where the cost is coming. So it's an enormous impact for us and a massive impact on that budget every year. It's very expensive. Can I have the next? Okay, so we talked a lot about diabetes and type 1 and type 2. We've talked a lot about the impact of diabetes and the enormity and the cost of diabetes. But what actually is diabetes? I'm going to ask to show you now a short film which is going to explain it far better than I can, and hopefully we'll have a better understanding afterwards of what diabetes really is. I do apologise that the film isn't working. I've no idea why. It did when it was tested. I can only blame Zoom, I'm afraid. But what we will do is we will send that link out to that film so that everybody can see it. So I'll just have slide 10 then, please.
You just need to go to
There you
slide.
go.
There we go. Oh, brilliant. Success. Thank you. Sorry about that delay, everybody. Okay, so really sorry we couldn't see the film. So I'm going to move on because obviously throughout today we are going to hear a little bit more about what diabetes is, so don't worry about that. But as we know, diabetes can actually be a really serious and have long-term complications. And so we know that diabetes affects every part of the body. And so every week we have, 460 premature deaths aligned to diabetes. There are people that are unfortunately losing having lower limb amputations because diabetes can really badly affect their feet with ulcers and things like that. So we know that that's happening every week. We know that there are people that are experiencing heart attacks and heart failure, and also 540 people every week that are experiencing strokes. It also affects, you know, the kidneys, and we know that there is 270 people that are needing a renal replacement therapy. So as you can see, from a physical perspective, diabetes is really serious and it can affect lots of parts of the body. But the other thing I wanted to mention was that these are the physical things that obviously that diabetes can affect, and your eyes are another, you know, another way that diabetes can badly affect you. But it also has a massive mental health strain on people. It's because it's a long-term condition, because it can be relentless. People really struggle with their emotional and psychological well-being. And so diabetes as a condition really can affect people quite significantly. Next slide, please. However, what I really want to say to you is whilst we know that diabetes can cause complications for people, it's really important to remember that you can live well with diabetes. And the message I want to give to everybody is that, you know, if there is a diagnosis of diabetes or you're in that pre-diabetes state, you know, there is information and support out there, and please do access it. It's important that everybody understands the condition, and people need to understand the impact of diabetes and what it actually is. They need to maintain a healthy lifestyle, i.e. to stop smoking. Keep up with that healthy diet, and really important to keep active. And the last thing really to say to everybody is, you know, in order to support you to sort of self-manage well and to live well with diabetes, you need to know where to get the right support, and you need it when you need it. Next slide, please. I'm just going to very quickly touch on this. This was, I just wanted to share this with you because Diabetes UK do run a number of different campaigns over the last few years, and this one was really aimed at children with diabetes, and so many children were going misdiagnosed. And I suppose this is really focusing on the signs and symptoms of diabetes, and if we don't know what those signs and symptoms are, things can get pretty serious for us. So although this was really aimed at people with type 1, I really want to kind of send the message out to everybody that actually this was what we call the 4 T's. So if somebody's going to the toilet more frequently, if you're going to pee a little bit more than you would do normally, if you're thirsty because essentially your kidneys are trying to flush out that high sugar in your body that shouldn't be there, and also feeling very lethargic and tired, but you're also losing weight, please go and speak to somebody. This is what we call the 4 T's. So any of those, please do go and seek some help. It's really important that you take note of those things. And the next slide, please. Okay, so very briefly, Diabetes UK is who I work for, and they are the leading diabetes charity, and we are tackling the diabetes crisis. This is the front page of our website, and I just wanted to give a clear message to everybody that we are here for everybody affected by diabetes. And once you click onto our website, this is what will come up, so you can find out more about type 1, type 2, what the signs and symptoms are, whether you're at risk, and then there's tailored advice to move on to whatever you wanted to find out about. There's a learning zone there with a whole plethora of information for people, so please do go on our website, and we can certainly help you from there. Next slide, please. And along with the website, I just wanted to briefly mention that there are peer support and local groups. I'm sure we'll hear more about those later on today. We do have our helpline number there, and I know that's going to be shared out with you, and also a helpline email address. I briefly wanted to mention Learning Zone because that is for not just people with diabetes, it's also for healthcare professionals, and there are lots of courses and various different training sessions on there for people to learn about diabetes. We've also got our online forums and our shop, and we've also got a Midlands and East Facebook page. So there's various different ways in which you can get in touch with us at Diabetes UK. And if you have any concerns or any questions or queries, I urge you to do so. And thank you for listening. That's me. There's the website details, and I know that's going to be sent out to you with all of the other information after the event. So thank you for listening.
Thank you, Diane. That was a really informative start, if a slightly sort of shaky start. Apologies to everybody there. Not shaky on your part, Diane, shaky on our part. Apologies. I can just say and reiterate that all of this, the presentations and including the video, will be sent out to people at the end. So what you've missed you will be able to have check in later and have a look at it. I'd now like to introduce Dr. Kerry Salis, who is a GP and also the diabetes clinical lead for Nottinghamshire, and she's going to explain to us a little more about the patient's journey and the clinical perspective on diabetes.
Okay, hi, thank you. Just double checking with the technological issues we've had, can people hear me? Fabulous,
Yes,
okay.
Thank you, Kerry.
Thanks, guys. So yes, thank you for the introduction. I'm Kerry, I'm a GP, and also, as I said, the diabetes clinical lead for Nottinghamshire. So I've not done this, oh, fantastic, it's moved already. Next slide. So I know we've just talked about it, but again, like we've said, diabetes is when the sugar level becomes too high. Briefly, there are two types. In this presentation that will be shared, these should be links as well for you to be able to sort of read on it a bit more if you want to, but just to take it into the medicine, type 1 diabetes is when the organ in the body called the pancreas stops producing insulin, which is important in regulating that sugar level, and the pancreas stops producing it. Whereas type 2, if you think about it, it wears it out over time, which is where you tend to see type 1 diabetics predominantly being children, and type 2 tend to be patients in their sort of later years. Next slide. So just a little bit about where we are in Nottinghamshire and prevalence. Prevalence means the number of patients that struggle with diabetes. So men do get it a little bit more than women. And again, the data I'd got, between 15 and 39% of people aren't diagnosed. I'm sure if you go on 20 websites, the numbers might be a little bit different, but I think the point is that we do not know every person who is unfortunately struggling with this condition. And that the conical flasks showed 90% predominantly have type 2. If you think about that 3.7 million across the UK, there's about 55,000, that's right, isn't it? My brain's gone down. Yeah, patients struggling with this across Nottingham. Just in the way we structure the general practice across Nottingham, that's where the 3 mid-knots and Nottingham City and South Knots areas are, but that essentially is just showing that there is a spread across Nottinghamshire. Next slide. Main bit about this is to talk about the patient journey. So we've got Mr. Snap, a prize for breakfast I was eating as we move through these patient journeys. But Mr. Snap, he was worried about diabetes. So he thought he'd book a general practice appointment because he was struggling with some of the symptoms, feeling a bit tired, run down, thirsty, and finding he was going to the toilet more often. So we went into general practice and a routine blood test was organised, and that test came back, which is a HbA1c. If any of you are familiar with diabetes, this is the monitoring blood test that we use to look at diabetes. Essentially, breaking it down really basically, it's a red blood cell or hemoglobin that lives within your blood, and when you have sugar within the blood, it sticks to this red blood cell. And then if there is too much sugar in the blood, you can imagine more sticks to it, therefore this level goes up. So to have a diagnosis of diabetes, you need the sugar level to be 48 or above. So as you can see, crudely with this gentleman, his level was 60. So if we go on to the next slide, please. So this blood test does show that he had diabetes. So what happens at that point? So you most likely will have a doctor that will look at that result, but it doesn't necessarily mean that that patient will then come in to see a doctor for the follow-up appointment. I'm sure you've all had experience of the way general practice is changing now. We've got fantastic practice nurses and doctors who you're probably used to seeing, but we also have clinical pharmacists, or you might have a nursing associate. So the skill set of general practice is changing. So normally what a practice has is a nurse or a clinical pharmacist who are able to deal with patients who have these blood tests. Depending on the skill set of that clinician, the appointments will vary in the appointment length. So he might have an appointment in between 10 and 30 minutes. And then what happens for Mr. Snap? So The first thing will be, if you pull up the first little small one for me, will be that it's all then patient-led. That's the main thing that we want to be looking at whenever you have any general practice contacts. Patient-led opportunity to ask questions, talking about explanation of diabetes if they've never heard about it, and thinking about the management. This patient has diabetes. What do they feel? Do they feel that diet, looking at that might be helpful? Do they think medication would be useful for them? But I think the main thing is, it's only a 10 to 30-minute appointment. It's about supporting that patient, and a discussion will be happening about referring on to a supportive program. Next slide, please. So for patients who've been diagnosed with diabetes, you'd be looking at the Desmond acronym is there, management structured education program, looking at focusing on patients with type 2 diabetes. But the aim is to improve that understanding. I'm sure lots of people, I've already seen one question already come up in the chat today. Being given this significant diagnosis will always generate more questions. And I'm sure we've all fallen foul of that, walking out that clinical room and thinking, oh gosh, I wish I'd asked X, Y, and Z because I'd only asked A, B, and C. So again, what the course does is it just gives you that time to understand, to re-ask questions, and promote that self-management of the condition, you know, linking back to what was said before about, you know, the diet and the exercise. It's about empowering patients. Next slide, please. So again, it's that signposting. Where can you get the support from? Because a patient does not have diabetes just for that appointment time. That is such a, for any of you that have diabetes, you know, the actual clinic time or any time that you have where you speak with a medical professional is realistically nothing compared to the time that you're living with it. So it's about supporting and moving you on to the people that are able to support you. And then next page, next slide, please. Moving you from a diabetic patient, Mr. Snap, to actually Mr. Snap who has diabetes. That's where the empowerment comes from. 20 or 30 years, we used to label patients, you know, as a diabetic patient, or that HbA1c or that blood pressure. But we're moving away from that now and recognizing actually that every single person is unique and therefore they are a person who happens to have. And that's again what these programs are also about supporting to empower and own this condition, or dare I say, which I haven't really put much time into, the ability to actually reverse this and bring those sugar levels in back to normal, dare I say. But let's move on to our next slide then. So this is Mrs. Crackle. So she comes in for her annual blood pressure check, and the extremely good HCA, who's been doing the blood pressure and the bloods, has noticed that unfortunately Mrs. Crackle has a raised BMI, and whether or not anyone is aware, a raised BMI and weight is a risk factor, unfortunately, for diabetes. So as well as the bloods that are needed for blood pressure, she does a sugar check for that patient, and this one comes back at 47. So this is not diabetic at that 48 we discussed. So what does this actually mean for Mrs. Crackle? So if we go on to the next slide, please. So this test actually shows the pre-diabetes that was discussed earlier, or what you might also hear, you hear pre-diabetes or impaired glucose tolerance. They are the exact same thing. Don't think they are two separate conditions. It's a bit like chest infection and pneumonia. Sometimes these words can be interlinked. You have normal sugars, you have pre-diabetes or impaired glucose tolerance, and you have diabetes. And 50% unfortunately will go on to develop diabetes. So what happens for Mrs. Crackle? So again, this blood test is looked at, and an invitation for a nurse or a clinical pharmacist appointment. You might find this appointment is a bit shorter because it's not a diagnosis of diabetes. We need to think about these sort of test results as warning shots. So again, what can Mrs. Crackle expect from her consultation? Again, patient-led, opportunity to ask questions, explanation of pre-diabetes, a chat about diet. But again, as you can imagine, and we come back to what we said about the diabetic appointment, this is only 10 or 20 minutes. This is not the Mrs. Crackle's life. So again, we're referring on to that supportive program. So this supportive program is called something different and run by someone different, and it's called Healthier You. And again, it's a 9 to 12 month program, which again can help to guide and look at those things that we've already talked about: diet, exercise, and living well. So again, next slide, please. Exact same principle. It's about signposting. It's about informing of the information. Oh, we've jumped on. Oh, we're back. And empowering the patient to be able to understand and manage their condition themselves. So we're on to the last one. So Mr. Pop. So he has celiac disease, which for anyone that doesn't know about that is a condition where you're not tolerant of gluten. And if you eat gluten, what happens is your body has an immune reaction to the gluten and it can upset your tummy and make you quite unwell. But this is what we call an immune condition, sorry. And so sometimes this can mean if you have one of them that you can be at risk of others. So he'd been asked to book his annual sugar test just to see whether or not he was at risk or had developed diabetes. And his sugar level came back at 38. So at the moment, Mr. Pop does not have diabetes or pre-diabetes, but he is at risk. So we ask him to have his blood test every year. So if we go on to next slide. So in coming back to how do we identify, we've talked about, a significant number of patients or people across the UK. How do we pick up this condition? So if we're thinking about pre-diabetes or that impaired glucose tolerance, it's very, very, very difficult, I think is the honest answer, because the majority of times, those 4 Ts that we talked about before, patients don't have them. They're what we call asymptomatic. They don't know they have it. So you don't really know who to test and who to support and who to ask to come in to see whether or not they consider a blood test. And it's not recommended by NICE, who is the body that recommends how we treat patients, to offer, the population this blood test annually. Therefore, the only thing that we can do is either A, do it if a patient is concerned with regard to the blood test, or we have lists of conditions, unfortunately, just to medicalise things a little bit so that we can pull up patients who we think might have a risk of developing diabetes. So if you go on to the next slide, please. So this is just a list of patients that we would offer an invitation in to have a blood test. So again, with what I alluded to before, if their diabetes is resolved, impaired glucose tolerance, gestational diabetes, which is when patients become diabetic while they're pregnant, celiac disease, there's lots of conditions you can see here. Next slide, please. And then also what you have to link is it's almost thinking outside of the box. So we've talked about the impact of diabetes. It can have a risk on our cardiovascular system, essentially heart and blood vessels. So sometimes patients with high blood pressure or obesity, we also offer them blood tests. Unfortunately, we've noticed that our patients who struggle with their mental health, they again can be at risk. This is because they tend to live more chaotic lifestyles and they might find that their weights or they are a bit heavier, steroids and high risk groups. We know social deprivation is also linked or heavily linked to diabetes, as well as unfortunately BAME. That is a genetic risk due to sort of the way that the pancreas, if you think in type 2, doesn't work as well as it does over the years. Sometimes that can start to slow down a lot earlier than non-BAME patients. So moving on to the last few slides now. Just thought would make it a bit relevant for, unfortunately, the pandemic that we're all experiencing. COVID is affecting diabetes control. We're seeing a lot of patients discharged from hospital having been, completely, under control and them having their diabetes really well controlled. Unfortunately, COVID is just causing patients to need to be on insulin. So a lot more patients are unfortunately finding that they need to be looking at adding an insulin to their treatment plan. And following the first wave, they have found a third of patients who had COVID had diabetes, 1 or 2. And I think they also feel the risk factors are essentially related to their weight. And CKD is what we call chronic kidney disease, which is kidney damage related to the sugar. And I've also seen, unfortunately, that COVID has also triggered new onset diabetes as well. So there's lots going on, unfortunately, with regards to COVID. So given I also give 2 days a week to the vaccination centres, please get your vaccines, protect yourself, protect others. I did not put that in there. Diabetes is an eligibility criteria for the vaccine. If you've not heard anything, please contact your GP. I go mad when people say that because it does mean a lot of work for general practice. But if you're not sure, SwiftQ, I can put the name down in the chat, is where you can go on to start booking online, or 119. There are lots of stations open across Nottinghamshire. Please book your vaccine. But if we move on to the last one, so what we probably should have done is rethought about this slide, but also put on it, get your vaccine. But general practice is open. One of the things that I'm sure we've all seen, particularly during the start, was that nothing was open. General practice has never, ever closed. So it's really important to get yourself checked out if you're concerned. If you're not diabetic and don't feel well, even for whatever reason, contact your general practice. We are there for you. And we've also seen there's been some hesitation and reticence to pick up diabetes reviews. General practice is working differently now. We don't have to do everything, what we call face-to-face, coming into the surgery, doing so much more over video now. Skype, I don't know whether or not you can say Skype as an advertising, but those sort of principles over the phone. There's lots of different ways that we can be doing things for you now. So please get in contact if anyone is concerned. And then just quickly, might as well do it just while the question was there. Diabetes causes leg ulcers. Essentially, the sugar blocks up the very, very small arteries and veins. And then what happens is if you get a damage to the skin, as you can imagine, if the blood's not flowing round as well, it means that it can't heal as well. And that essentially is why you can get leg ulcers. Just to answer Rosanna Turner's question as well. That's me done. Thank you.
Thank you. Thank you, Dr. Salis. Quite a lot of important information there. So thank you very, very much, especially things I didn't know. I didn't realise that COVID triggered diabetes, so that was a new one for me. Dr. Salis did mention the Desmond programme. So for our next speaker, I'd really like to introduce Hannah Walters, who is the diabetes educator for the Desmond programme. And Hannah is going to talk about how eating well could actually be the secret to the prevention and management of type 2 diabetes. So thank you, Hannah.
Thank you, Jane. I think everyone should be able to see my slides. Can you see them, Jane? Yeah, can everyone see the slides?
Yes.
Yeah.
Thank you. Yeah. So as Jane said, I'm going to talk a little bit about eating well for the prevention and management of type 2 diabetes. So I haven't got a huge amount of time today, so this will just sort of be touching briefly on the topic of eating well. But obviously, if anybody's got any questions, just pop them in the chat and hopefully I can try and answer them at the end for you and also provide some additional information. So what I will do is I'll go through the Eat Well guide. So I imagine a lot of you will have seen this before. So the Eat Well guide shows how much of what we eat overall should come from each food group to achieve a healthy, balanced diet. So this balance doesn't need to be achieved with every meal, but we're aiming to get the balance right kind of across the course of the day or across the course of a week, say. So individuals with pre-diabetes or even a confirmed diagnosis of type 2 diabetes, there isn't a specific diet as such for these individuals. It is about sort of the general healthy eating principles, then trying to follow those with potentially a little bit more consideration around your carbohydrates, which we'll go on to discuss. And also, I guess, trying to manage a healthy weight as well. So like Dr. Kerry Salis said, weight can be a contributing factor to a sort of diagnosis of type 2 diabetes. So that's why managing weight is really important. So what I'll do is I'll go through each of these food groups in a little bit more detail and just give a little bit of information around them. So if we focus on fruits and vegetables firstly, I'm sure everyone's aware of the 5-a-day message. It's out there quite a lot now, isn't it, really? So we're aiming to have at least 5 portions of a variety of fruit and vegetables every day. And that's the case for the general population, but also individuals that have a confirmed diagnosis of diabetes. That can be fresh, frozen, tinned, dried, or juiced. they would all contribute to your 5 a day. In terms of fruit juice and smoothies, we should only aim to have 150 ml a day, and that's just because of how concentrated they are in terms of the sugar content. So anything beyond that wouldn't count towards your 5 a day. So fruits and vegetables, they're a great source of vitamins, minerals and fibre. And if we're thinking about our plate, we'd want to have half of our plate full of salad or veg really at our main meal times, because that's there as our filler food almost, and it provides the main bulk to our meals. So for individuals with diabetes, there's often a lot of questions around fruits in particular, and whether they should still, have fruit within their diet. For individuals with diabetes, we just sort of say to aim to have at least one portion of fruit at a time and spread those portions out throughout the day. So it's still trying to meet the minimum 5 portions of variety of fruit and veg a day, but potentially having more portions of vegetables and slightly less with fruit just because of the sugar content. So fruit does contain a natural sugar called fructose, which can have an impact on your blood glucose levels. But again, we're trying to sort of have the whole fruit more so rather than our fruit juice and smoothies, just because it's broken down more slowly in our body and therefore causes that more gradual rise in our blood glucose levels. Okay. We'll then have a look at our protein food group. So by protein, we mean things like our beans, our pulses, fish, eggs, meat, etc. So protein is really important for growth and repair, and also it contains, other vitamins and minerals as well. Ulcers, and by that, as I mentioned, beans, peas and lentils, they can be a really good alternative to meat because they're sort of naturally lower in fat, but also a good source of fibre and protein. So they can be sort of quite a good way to bulk out our meals, or go for obviously vegetarian sources of protein on set days, for example. If we are having meat, that's again absolutely fine, but it's trying to go for leaner cuts of meat and sort of lean mince, and trying to have less red and processed meat. So for example, our bacon, our ham, sausages, etc. We're aiming to have at least 2 portions of fish every week, and one of which should be oily fish. And by that, we mean things like salmon, mackerel, trout, herring, etc. And for individuals with diabetes, there is evidence to suggest that 2 portions of oily fish a week have been proven to be beneficial. And that's because oily fish contains omega-3, which is really good for our heart health. It's almost like hair conditioner for the blood vessels. So trying to get the oily fish within our diet. We focus on what we call our starchy carbohydrates. So by that we mean things like our potatoes, our bread, our rice, our pasta, etc. So carbohydrates, the food group that have that direct day-to-day impact on our blood glucose levels. And often people get quite concerned about their carbohydrate intake when they have a diagnosis of diabetes. We do still need carbohydrates within our diet. They're our main source of energy, and they provide us with a range of nutrients. I guess we're just considering the amounts that we're consuming, so portion sizes, and also potentially the type of carbohydrates that we're going for. So different carbohydrate foods are broken down differently within our body. Some will be broken down quite quickly, causing quite a sharp rise in our blood glucose levels, whereas other carbohydrate foods will be broken and sugar, and generally carbohydrates with a higher fibre content will be broken down more slowly. And you may have heard that referred to as low GI foods or glycemic index. I'll talk a little bit more about that if I get a chance later. So if we move on, we've got dairy and alternatives. So dairy is a really good source of the calcium, which obviously we need to keep our bones healthy and our teeth. So we're aiming to have the equivalent of about a pint of milk a day. So that could come from 1/3 of a pint of milk, a small sort of pot of yogurt and a small matchbox size of cheese, and most of us will meet our calcium requirements if we had sort of that amount really. Still considering going for lower fat and lower sugar options, so reduced fat cheese or more of our plain sort of lower fat yogurts, because we're just being mindful of the fat content and sometimes how much sugar is added to certain products. With regards to milk and milk products, they do again contain a natural sugar, which is called lactose. So they will have an impact on our blood glucose levels, but they have many additional health benefits. And generally it's a far more gradual impact again. So we're not sort of too concerned by the sugar in terms of this food group. So oils and spreads, there are types of fat. So fat is the most concentrated source of calories. So fat is the most energy dense nutrient. So for that reason, it can more readily lead to weight gain. So in terms of fat, we're trying to have less fat overall within our diet, and where possible, going for the unsaturated sources of fat because they're healthier and they're better in terms of our heart health. And examples would include vegetable oil, rapeseed, olive oil, sunflower oils, corn oils, for example, and any spreads based on any of those as their main ingredient. But all types of fat, as I mentioned, are high in energy. So even if we are going for the unsaturated sources, we do still need to be mindful of how much we're actually having. The high fat, salt and sugar foods, you probably notice that they don't actually sort of feature within the Eat Well guide. And I guess that's because we don't technically need them to make up a healthy, balanced diet. So they don't really have a huge sort of nutritional value. And so for that reason, as I said, we don't particularly need them. But that's not to say that they won't still be included within our diet. Even for individuals with diabetes, there isn't that specific diet. We don't have to cut out these foods completely. We may just need to consider having them less often or in smaller quantities. And the kinds of foods and drinks would be, our chocolates, our cakes, biscuits, our sort of full sugar, soft drinks, ice creams, etc. So if I just focus a little bit more on carbohydrates. So as I mentioned, carbohydrates are the food group that have that direct day-to-day impact on your blood glucose levels. So you almost see carbohydrates as like the umbrella term. And then within that, we've got our sugary carbohydrates and our starchy ones. And as you can see from this slide, we've popped a few examples of each of those down. So generally, our sugary carbohydrates will be broken down quite quickly within the body, and they'll cause quite a sharp rise in our blood glucose levels, which causes our pancreas to be a little bit overwhelmed by that almost. So the pancreas has got to work really hard to deal with those rise in blood glucose levels, and it gets a bit overwhelmed as a result. Whereas most of our starchy carbohydrates, they're broken down more slowly. So it's almost like more of a drip effect of glucose into the bloodstream, which allows the pancreas to be able to pace itself and manage that workload a little bit better. And that's kind of what we refer to as Glycemic Index, which is the rate at which different carbohydrate foods are broken down within our body. We've popped fruit and milk products in a heart there, because as I mentioned earlier, yes, they do contain natural sugars, so they will still have an impact on our blood glucose levels, but they have so many additional health benefits. So we still need carbohydrates within our diet. We just have to be mindful of the kind of frequency, the amount, and the type that we're going for. So just to sort of get towards finishing off, I've got a couple of plates here. Hopefully everyone can see those, and if you're unsure of what anything is, it's just listed below because I know they're not entirely obvious. So on the plate on the left-hand side, we've got quite a lot of carbohydrate on that plate. So we've got 2 Yorkshire puddings, 6 roast potatoes, and 2 scoops of mashed potato. So that meal as it stands will have quite a significant impact on our blood glucose levels and cause quite a sharp rise. And again, the pancreas would feel quite overwhelmed as a result of that. Whereas on the plate on the right-hand side, we've reduced the carbohydrate content. So you'll notice that we've taken away Yorkshire pudding, we've halved the amount of roast potatoes, and we've also taken away the mash. So the carbohydrate content has been significantly reduced, which will cause more of a gradual rise in blood glucose levels and allow the pancreas to cope with that better. If we look at the proportions on the plate on the right-hand side, we've generally got a half, quarter, quarter. So half of our plate would be vegetables, or it could be salad, and then the other half split into 2 quarters. So a quarter carbohydrate, and by that we mean the Yorkshire and the roast potatoes there, and then a quarter protein, and we've got roast beef in this example. So half, quarter, quarter is a really good sort of rule of thumb to go by, really. We're not saying every single mealtime will look exactly like that, but it gives you a good guide to work towards and sort of consider whether or not you need to reduce your portion sizes of your carbohydrates in particular. And just another example here. So on the right-hand side, we've taken away the naan bread and replaced it with salad. And we've also reduced the portion of rice by a tablespoon to just try and reduce the carbohydrate content of the left-hand plate somewhat. So this acronym is something we use quite a lot within our Desmond courses, and I'll just explain Desmond very briefly in a second. So we consider frequency, amount, and type, and I guess it's applying that principle to your food choices as a whole. So actually, if you have something quite often that you perhaps think maybe you shouldn't, can you reduce the amount that you're having, or is there a better type that you can go for? Or actually, if you don't have something that often, is it a case of you just want to enjoy it as it is, but you've reduced the frequency? So Desmond, I think other people have already really mentioned this, so I won't focus on it a huge amount. But Desmond is a group education program for individuals with a confirmed diagnosis of type 2 diabetes. It's 6 hours of structured education, which at the moment we're delivering it via video conference over Microsoft Teams in the format of 3 2-hour sessions. But normally it would sort of be face-to-face education. The referral criteria is anyone that has the confirmed diagnosis of type 2 diabetes and you're over the age of 18 years old with a Nottinghamshire County GP. But there is also a Desmond service across Nottingham City, which is run by City Care. So that is an option if you live in that area. And for our service, we accept self-referral or primary care. So by that, we mean, your nurse or doctor or someone at your GP surgery. And there's our contact details and our social media. And these slides will be available to you after the event today. That's me. Thank you.
Thank you, Hannah. That was really informative, and I'm delighted to know that I can still have my Yorkshire pudding. Can I just explain to people, I'm really sorry, we are, due to our technical issues at the beginning, we're running a little bit over time. We may make that up, but we're about 10 minutes over time at the moment, so please bear with us. So if you've got a diabetes diagnosis, it is really especially important that you look after your physical health, your self-care. So I'm now delighted to introduce Luella Robb, who is a diabetic specialist nurse from one of our own medical centres here in Newark, the Lombard practice, and she's going to talk to us about the signs and symptoms that we need to look for. So you're very welcome, Luella.
Hi, I am looking a little bit surprised because I thought I'd been asked to talk about the complications of diabetes. We have tried to clarify this over the last few days. However, we can do a bit of both if you want.
Thank you. Well, thank you very much. Yes, the complications that people do find would be lovely. Yeah. Thank you very much. Yeah.
Signs and symptoms. I'm sorry, I haven't been able to listen to the previous presentation, so I hope I don't overlap anybody else's. But if you have undiagnosed diabetes, the most common signs and symptoms are increasing thirst, dry mouth, needing to pass urine more often at night particularly, more tired than normal, increasing skin infections, particularly like thrush down below, that sort of thing. anybody who's worried about diabetes and develops any of those symptoms should really be asking for a blood test. As Jane said, I'm actually a nurse practitioner employed at Lombard Medical Centre. I am a diabetes specialist as well, and as one of my roles at the surgery. I'm going to talk a little bit about the potential complications of diabetes and what you can do as patients to prevent them, and what we at the surgery do to try and help you prevent them. Is that okay, Jane?
Sorry, I'm muted. Apologies. Yeah, no, that's really lovely. It'll be very informative, and thank you for. I'm really sorry that I introduced you as the wrong thing.
No, that's fine. That's fine. It is a slightly depressing presentation. I'm sorry, and I don't have any slides to show you. I'll try not to make it too ghastly. The majority of the complications of diabetes are caused by extended periods of a high blood sugar. And this damages nerve endings throughout the body and small blood vessels throughout the body. The nerve endings and blood vessels that supply the body's organs with nutrients and oxygen. So as you can imagine, that has a knock-on effect on basically just about everything in the body. The damage can take up to 15 years to show effects, in the kidneys and the eyes and heart attacks and things. So when people are first diagnosed, it can feel a little bit unrealistic and unnecessary to worry too much about what's going to happen in 15 years. And that's a common problem in our management of patients. And in a diabetes review appointment at the surgery, we are testing and monitoring for all of these complications very regularly. So what I thought I would do, just to highlight some of the complications, is just work through from the top of the head down to the feet, and just go through a few of the potential problems that can occur. And just to reinforce, all of these problems that can occur, the majority of them are much more likely in poorly controlled high blood sugar diabetes. They are much, much, much less likely in well-controlled diabetes, and very, very, very unlikely in pre-diabetes. Okay, but it's good to know what these things are, because if you're trying to prevent yourself from getting diabetes, then these are the reasons that you want to do it. So starting at the top of the body then, the head, there's an increased risk of having a stroke. This is caused by the damage to the lining of the blood vessels, leading to plaque and clot formation. It's fairly common for diabetic patients to have TIAs, which are minor temporary strokes. They should always be taken very seriously, as there is an increased risk that a full stroke might follow. So any symptoms of a temporary loss of speech, temporary loss of sight, or temporary loss of use of an arm or leg should be reported to a doctor straight away. There's some research now that suggests up to 90% of diabetics have a higher risk of serious stroke and heart attacks, so it's well worth being aware of that one. Next down the body are the eyes. Diabetic retinopathy and diabetic maculopathy are the two conditions that can affect the eyes. Again, both caused by damage to little blood vessels at the back of the eye. Diabetes is the leading cause of blindness in working age people. It's not got a huge amount better, although our diabetes care has got better. The rate of retinopathy is still really quite high. The damage is done to the tiny blood vessels at the back of the eye and the retina, and this can cause leaking of the blood vessels and tiny bleeds. We don't do it ourselves, but patients are called every year for diabetic eye screening, where photographs are taken of the back of the eye, and those photographs are stored and monitored each year, and new photographs are taken. If necessary, retinopathy can be treated with laser surgery or laser therapy. It's not always successful, but it's pretty good. But it can only work if people go and have their tests done and catch it nice and early. Next down the body is the risk of heart attacks and heart failure. Again, due to the damage to the blood vessels and nerves supplying the heart. The risk of having a heart attack for somebody with diabetes is the same risk as somebody who's already had a heart attack. So that's an increased risk on the general population. High blood pressure and high cholesterol are quite common in patients with diabetes, and this also increases the risk of heart attacks and strokes and heart failure. Next one down I've got here is one that's not heard about quite so commonly, and is down to the nerve damage that can be caused by diabetes. Now this can actually happen, this neuropathy can occur in nerves all over the body, but one that is sometimes forgotten about is gastroparesis, or diabetic abdominal neuropathy. And this is caused by damage to the nerves that supply the stomach, and mean that the stomach empties more slowly than it should. And this can cause nausea, vomiting, and abdominal pain. Right, sorry, it's all a bit grim, isn't it? The next one down is the kidneys. That's the next part down in the body. So kidney damage can occur for the same sorts of reasons. The small blood vessels that filter blood through the kidneys become damaged, as do the nerve endings surrounding those blood vessels and the kidneys, so that they don't work properly. And that's a progressive thing, mostly in people with diabetes. They start off okay, and then they slip a little bit, and each year they slip a little bit more, and they slip a little bit more. It's estimated that up to 40% of diabetics get some sort of kidney damage. Some of it's fairly stable and doesn't progress much, but there are quite a lot of people who progress to needing kidney dialysis still. There are 2 tests that we do in the surgery for kidney disease. We do a kidney blood test, and then we do a urine test for tiny amounts of protein, which can be a very early indicator that there's some diabetes damage happening to the kidneys. So they're the tests that we do here for that. The next level down are sexual problems. The same nerve and blood vessel damage that causes heart attacks and strokes can cause erection problems, can also cause vaginal dryness in women, and some loss of libido in both men and women. So that's often a good indicator. Sometimes we diagnose people from erection problems. There are medications that can help, but keeping the blood sugar, the cholesterol, and the blood pressure well controlled are your best bets. And then last, how am I doing for time? Last but not least, at the bottom of the body, we've got the feet, which obviously cause a lot of problems. So foot problems occur because of nerve damage. Nerve damage results in loss of feeling in the feet, so damage and infection sometimes isn't noticed. And then the poor blood supply causes poor healing and deep-seated infection sometimes. Diabetes is a leading cause of toe and foot amputations in the UK, and diabetics are about 15 times more likely to need an amputation than the general public. Obviously, this risk is increased further if in smokers. So that's a rather depressing run through from head to foot of some of the complications that diabetics can get. As I'd like to, again emphasize that these are normally risks of poorly controlled, long-standing poorly controlled diabetes. The odd high spike of a blood sugar for a week or two or a month or two that's then resolved again will not necessarily lead to all of these problems. It's more the chronic high blood sugars that go on year after year after year. Once somebody is diagnosed here with diabetes at the surgery, all our efforts are aimed at keeping the blood pressure, the blood sugar, and the cholesterol levels as well controlled as possible. As I say, we don't organise the monitoring of the eyes, but we do check that it's being done and encourage people to attend if they haven't. We do the foot checks, the blood pressures, all the blood tests and urine tests. And that's all in an effort to reduce the risk of these complications. And we're still strongly advising and encouraging patients to attend all of their appointments at the doctor's surgery. We are open, and we're all here ready. If you've been diagnosed with pre-diabetes, then you've got a golden window really of opportunity to improve your blood sugar, prevent the diabetes, and hopefully prevent all of these complications. I think I don't want to step on anyone's toes, as already talked. So I'll just say that, it's not all down to you. There are a few people with strong family histories who might not be able to prevent it, but on the whole, improving lifestyle issues should reduce your risk of diabetes and of the complications if you do get diabetes. So losing weight, eating a healthy, well-balanced diet, the small amounts of fat and sugar, getting as much exercise or activity as possible, attending the National Diabetes Prevention Programme, or Desmond if you're diagnosed with diabetes. They're all things that you can do to reduce your own risks. There's some good evidence for low carb and low calorie diets. If that's something that you're interested in, there's plenty of advice on the internet about that. smoking and high alcohol intake can contribute to all of these complications. So again, efforts should be made to modify or stop that. Hope that wasn't all too depressing. Is that okay?
I am not at all depressed. All I can say is thank you very much for giving us that head to toe whisk through. What
it was a bit of a whistle stop.
And absolutely, the most important thing to mention, I think, is that we should be controlling it if we believe we have diabetes, not ignoring it. It's not, as you can see, all about our physical health, but it's also sometimes our emotional well-being. And so it gives me great pleasure to introduce now Marie Crowley from Insight Healthcare, who is going to talk to us and explain how our emotional health can be affected as well. Thank you.
I hope I'm not the first one to unmute my mic. It's a standard comment now, isn't it, when we're talking to each other online. So, hi, my name is Marie, as Jane's just said, and I'm the service manager for a charity that works across Nottinghamshire and Derbyshire, providing talking therapies. So who are we? So we're a national charity. We provide services up and down England. And as you can see from the logo in the top corner of the presentation, it says Insight IAPT. And what is IAPT? I hear some of you say. It stands for Improving Access to Psychological Therapies, and it's been part of a government scheme for the last 10 years. To promote emotional well-being as much as physical well-being. It was originally started to get people back to work who were off with anxiety and depression, but it's grown a lot since then, and now we work with people with physical health conditions where emotional well-being is a really important part of that. Okay. So, diabetes, how do you feel about your diagnosis? So as Jane's just said, you know, diabetes isn't just about how it affects us physically. It can affect us emotionally too. When we get a diagnosis, we can feel that we've lost that sense of control over what we eat and how we live our lives, what we can and can't do. It can make us feel quite stressed if we don't really understand everything around our diet and testing and medication. And it can also feel that it's not happening to me, I'm not going to acknowledge it, and I'm not going to change the way I live my life because I don't think that I'm at risk. And that is a really normal reaction to have. Anybody who receives a lifelong physical health condition can feel that way. Everything that we take for granted around what we eat, what we drink, how, you know, we act on a day-to-day basis, when we're suddenly told we can't do that anymore, then it can create that sense of denial or feeling stressed, and that is okay. That is okay. That's a normal part of receiving any kind of diagnosis, and that's why we work with people not just with diabetes but with heart conditions, with respiratory conditions, muscular conditions. So we work with a lot of physical health conditions. So when we can feel quite low, it takes us into a cycle, what we call a cycle of depression. And it's that chicken or egg, as it says in the cartoon. Are we depressed because we have diabetes, or is our diabetes causing our depression? And both of those things are true. Because when we feel depressed, we lack energy, we lack motivation, we have low interest in you know, day-to-day life. We can feel fatigued as a result, and that means that we can feel that we just don't move around, we stay indoors more, we don't see our friends and family, and we start neglecting our responsibilities. And that can lead to us feeling guilty, feeling hopeless, feeling overwhelmed, and feeling like a failure, which in turn makes us feel even more depressed. And that can all be an indicator for being at risk of complications, as well as just spoken about, as well as having poor diabetes management. So our mood can affect our blood sugar, because we're more likely to eat junk food when we're feeling low energy. Okay, next slide, please. Okay, so as I've just talked very briefly around, we are now working together with physical health services, which in the past have been provided separately. So you saw your diabetes specialist over there, and then you would access psychological support for anything, you know, as a result of your diabetes diagnosis in another team. Whereas now we work together in what we call integrated pathways, because around 40% of people with depression and anxiety also have a long-term health condition. And mental health issues are found in around 30% of people with a long-term condition, and around 70% of people who've got medically unexplained symptoms. So that can be physical symptoms that there's just not finding any diagnosis for. So the patients that, you know, come along into our service in terms of going on to the integrated pathway for diabetes, psychological well-being is seen as equal as physical well-being, as equal as your blood sugar and blood tests and medication, rather than being a separate team. So it's become a fundamental part of your treatment. And if you've not been offered that, then that is something, you know, certainly worth talking about with your diabetes nurse or specialist. So how can we help? So can we go back one slide? Thank you, sorry. So if you've got low moods, living with diabetes can feel really tough, and we can feel quite down, and we can experience what we call diabetes burnout, where that exhaustion of trying to manage your condition day after day, especially if your blood sugars are quite variable and you're struggling to get on top of those. So we can help you to feel less overwhelmed and defeated by having diabetes. We can work with you to try and change your mindset, to learn to live well with diabetes. And the same with anxiety. It's really common and it's really normal to feel anxious about diabetes at times. And sometimes, you know, if as a species we wouldn't be around today if we didn't have anxiety, because it keeps us safe, it keeps us from doing things that harm us. But in the 21st century, you know, we no longer need to protect ourselves from predators. So anxiety plays out in different ways. So it can affect your sleep, it can affect how you are in, you know, meeting with people, your work. So when we feel anxious, we feel wound up, nervous, worried, or tense. And those feelings can range from feeling just a bit butterfly-ish to full-blown panic attack. So it's really important that we work with you to address anxiety, because that will help your management of your sugar levels. Next slide, please. So, as I've said, we can help you to adjust to your diagnosis and to challenge any negative thoughts or any overwhelming thoughts that you have around the management of diabetes. We can help you address any feelings of low mood, whether that is through cognitive behaviour therapy, counselling, or supporting you to access antidepressants by your GP if we feel that you need those. And also we can help you cope with any anxiety about diagnosis and throughout your lifetime at any point. We are an 18+ service, but also helping you to cope with the day-to-day stress. Next slide, please. So how can you refer yourselves? So for those of you that live in Mid-Notts, that's Mansfield, Ashfield, Newark and Sherwood, we are your only provider. So we are Insight IAPT. You will get all this information in the slides that get sent out after. So there's our contact number and our website. We've just launched our new website. If you live in Greater Notts, that's Nottingham City and the south of the county, you can access either ourselves or there's two other providers, Trent Psychological Therapy Service and Let's Talk Wellbeing. They are exactly the same service as ourselves. We just, it's around patient choice in the city and the county south. Next slide, please. I think that is me.
And I think that is your last slide, Marie. So thank you very, very much for that. Really informative. So if you feel that you might have diabetes or be pre-diabetic, and I think there's always a worry that after lockdown, there might be more people with this condition. We've all eaten a bit too much. We've all drunk a bit more than we perhaps normally did. So who's there to help, and how do we contact them in the first instance? So I'm delighted to introduce Indy Darrowell, who will talk to us about living well, taking control, and about referral through them. Thank you, Indy.
Thank you, Jane. So good afternoon, everybody. So my name is Indy Darrowell, and I am the Support and Performance Manager for Living While Taking Control. So who are we? Living While Taking Control are the providers of the National Diabetes Prevention Programme. We have been delivering this service since 2016, and we deliver across various locations all over the UK. So the main purpose of our programme is to support service users who fall into this pre-diabetic range that may have been previously mentioned. We work to reduce their risk of developing type 2 diabetes through making healthier long-term lifestyle changes. So our programmes work to support you in making changes such as reducing your weight, introducing a more active lifestyle and eating a healthier diet. So the programme is available and delivered to the entire Nottinghamshire region. So this includes areas such as Nottinghamshire County and Nottingham City. So if your postcode or general practice falls within the Nottinghamshire region, you are eligible to join. Next slide, please. So what are the key benefits of joining our service? So accessing the programme is completely free. And once you sign up, you'll be allocated your own personal coach that will contact you to get you started and support you from the start of the programme all the way to the end. So our coaches support you in setting achievable goals that will help you to achieving a healthier lifestyle. So as well as reducing your risk of developing type 2 diabetes, the coaches work to support you in reducing other serious complications that have been mentioned that may be associated with type 2 diabetes. So these can include reducing complications such as kidney failure, heart disease, and stroke. Within the programme, you have the option of attending group sessions with peers just like yourself, or attending on a one-to-one basis based on what you prefer. And whilst attending the sessions, you will also have access to a free app that will support you for life, which we'll discuss a little bit further into the next slide. The next slide, please. So what is involved in our service? So once you have accepted onto the programme, you have the option to attend either our face-to-face programme or our digital service. So unfortunately, due to the pandemic, our face-to-face service usually would be delivered on a community basis, but it's currently delivered in the comfort of your own home via a video conference service. We also offer a dial-in service for those that may not be able to attend through their Wi-Fi. They may not have an internet connected device. The face-to-face programme consists of 13 group sessions that are spread out over a 9-month period. These sessions are booked based on your own availability, and each session lasts roughly around 60 minutes. Within these sessions, we offer peer-to-peer support, so the group sessions will be filled with people like yourselves who are looking to reduce their risk and have a healthier lifestyle. We also offer the option of doing a one-to-one support service, which we'll discuss further in the next slide. Within the group sessions, we very much advocate bringing along your family and friends to support you further in making this change. Within the programme, we cover a range of topics such as healthy eating, physical activity. We also discuss topics such as stress and how stress can affect our lifestyle, covering areas such as mental well-being, and again, how these can affect our lifestyles and affect our eating and our physical activity that we might be doing. Each participant is offered access to all of the resources in a digital app for free. And even once you have completed the programme, you have access to all of these resources as a lifelong. Next slide, please. So our digital service is another option that is available for participants that prefer a more one-to-one approach. So this may be beneficial to you if you have a busier lifestyle and are looking for a more flexible structure or prefer the one-to-one structure. So if you're somebody that may be working shifts, you may have a really busy lifestyle and you can't stick to a normal group session, doing this one-to-one approach using this digital app will be really beneficial for you. Using an app-based platform, you can track your goals and receive support from your virtual coach to make lifelong changes. Next slide, please. So we've put together a little case study which shows the thoughts of a participant who is currently attending the group sessions, and they're attending it through a video conference service. So this patient has found the programme beneficial as it's eliminated any need for travel and it's been in the comfort of their own home. So they found that it very useful to be able to speak to their coach on a one-to-one basis and found it very useful for them to achieve their healthy lifestyle goals. Next slide, please. So within Nottinghamshire, these are a few of our locality coaches that currently deliver the Living While Taking Control programme. So all of our coaches reside within the area local to yourselves. So they have local knowledge of the community centres and the support services that are available to you. As detailed within the images, you can see that the coaches have various levels of knowledge to be able to support you. So Harvin, for example, is a qualified personal trainer. So he has a lot of vast knowledge in terms of physical activity, in terms of nutrition, and will again be able to support you on a one-to-one basis to make some smart, achievable goals. Within Nottinghamshire, we also have a number of coaches that speak various dialects to support service users where English may not be their first language. So within Nottinghamshire, our locality coaches speak languages such as Punjabi, Urdu, and Polish. Next slide, please. So how can you find out whether you are eligible for the programme? The link on the slide and the QR code provided will be provided to you after the presentation. But once clicking on the link, you'll be able to direct yourself to our Know Your Risk tool. So to complete this tool, all you need is your height, weight, and waist measurements to determine whether or not you are at risk of developing type 2 diabetes. The tool takes no longer than 5 minutes to complete, and once completed, this will provide you with a score in which you are able to determine whether or not you are at risk. If you are at risk and you would like to continue with the programme, once you accept this, you'll be contacted by a locality coach local to your area to get you started on your programme. Next slide, please. And finally, how can you get in touch with us? If you do have any further questions or would like to get in touch, we've provided our info@lwtcsupport.co.uk email. So you can contact us via email to ask us any questions before referring yourself onto the programme. If you would like to contact us via telephone, we've provided a mobile phone number for our Compliance and GP Liaison Officer, Lucy Gibson, who covers the entirety of the East Midlands. And that's it from me. Thank you very much for listening.
Thank you, Indy. And well, so many experts. I don't know what I can say, how to follow that. But we do think that it's particularly important that we don't just hear from the experts, but we also hear from those people who are living well with diabetes. So it gives me enormous pleasure to introduce you to Mr. Jeff Clark, who has lived with type 1 diabetes for the last 36 years of his life. And Jeff will tell us all about it and how he has such a fantastic life. Thank you, Jeff.
Thank you, Jane. You stole my opening line there, but I'm Jeff Clark. I've lived with type 1 diabetes for 36 years. I have, over that time, I feel, become a little bit of an expert on it as well. But I'll let you make your own mind up on that as I go through this. When I was first diagnosed, it came as a bit of a surprise because I didn't feel unwell, but I just felt as I was getting a bit thin and that sort of thing. So I looked into the doctors, and when I learned I got diabetes by a simple blood test, there was no one more surprised than me, apart from my wife, I think, really. But I knew nothing about diabetes. I didn't even know what it was. I got this life-changing disease, and I didn't know what to do or anything about it whatsoever. I'd heard of people having diabetes, but I didn't know what it meant to them or what you had to do with it. But I soon realised that having type 1 diabetes, my pancreas had stopped working. So the only way for me to survive was to inject insulin into myself a number of times a day to try and maintain the correct blood sugar. And people have said to me over the years that, you know, I don't think I could do that. I don't think I could inject myself with insulin, but you soon come to the realization that you either do it or you're going to die. And that is the hub of the whole thing. You've got to do it. You've got to look after yourself. And no matter what it takes, you've got to be there for yourself. I was a classic type 1 diabetes patient, really, in terms of symptoms, because if I saw someone walking down the street, or I knew someone who said that, you know, I'd lost a load of weight, I was thirsty, I'd lost 3 stone, I used to be 12 stone, I got down to 9. I think it might have been 8.5, but my memory is not so good as it used to be after 36 years of it. I was thin, I was thirsty, I was drinking as much as I could. I thought I was going to turn into an alcoholic at one time. But I got over that. So, you know, after I was diagnosed, I spent the first 2 weeks in, there used to be a facility, a residential facility in Nottinghamshire called Langwith Lodge. I spent 2 weeks there after having a night in hospital. So I'd gone to the doctors, I got called to the hospital in the afternoon, I spent a night there, and then I went to Langwith Lodge for 2 weeks. And they did the treatment that's available through Desmond now or through other counselling services where they teach you, you know, about eating food, about injecting insulin, about checking, although rather crudely in those days, it was like having a chemistry set to check how much sugar was in your urine and that sort of thing. But you came up there, out of there with a little bit more knowledge than you went in there with, but you're still let out into the wild, very much so on your own, and then you've got to cope for yourself. And it's, you know, it's that self-survival that you need to have on this with, even now with diabetes, with all the help out there, you need to be looking after yourself. I had a further 2 weeks off work to gain confidence. I was driving 65 miles each way to work, as well as doing a 4 day's work on top of that. So I didn't feel as though, you know, I could go straight from Langwith Lodge back out into that. But I think my pancreas might still have been producing a little bit of insulin because it was just going up and down all the time. So I didn't feel confident to do other than I did, is just sit back a little bit and let it go by. They were quite understanding at work and they let me do that. But the bad times came again and I had to go back to it. It's like being in lockdown, isn't it? So having done that, I decided, you know, the work I was doing, I've got to review this. It's not something I could continue to do to keep driving like this. So I went through, I tried several things. I went back to university to do accountancy and that sort of thing. I used to sail, but I still managed to keep on doing it. That was fine. The rest of the lifestyle, I looked at diet and everything else, just trying to cope with what we were faced with, because we've got a lifelong condition here. I was only 30 at the time, relatively rare for type 1 diabetes, usually a bit younger than that. Or for type 2, you may be a little bit older, but at 30, you know, I've lived with diabetes now for more than I've not lived without it. And that's been the future. So with diabetes, the mental awareness of it is not that far away from it all of the time. There's only a few minutes of every day that I think, that I'm not thinking about diabetes. I'm thinking about what is my blood sugar now, what I'm going to have to eat. I'm always looking at food in terms of Has that increased my blood sugar? Has that insulin taken me down too far? You know, throughout the day, I'm checking my blood sugar regularly so that I know what's happening with me. You know, I'll check it before I have any breakfast. I'll check it a couple of hours afterwards. I'll check it before I have lunch. I'll check it a couple of hours after that. Before, I can tell you that I'm not doing it for fun, but it's because I want to know what's happening. Because, you know, pricking your finger 6 or 7 times a day is not much. It's not something that you look forward to, but it's essential, so you know where you're going with it. There are at the moment, or just come onto the market in the last couple of years, a thing called Freestyle Libra, which you may have seen on TV. These are patches that you stick onto your arm and just wave your phone over it, and that'll tell you what blood sugar is. They should be available to everyone taking insulin for control of diabetes, in my opinion. The NHS won't agree with me on that because it's too expensive to do so. But I think, you know, in terms of controlling your condition, being aware of what's happening to you, it just makes life so much easier. I used to be in meetings and, you know, I'd think, well, that meeting's going to finish at 12 o'clock, so I'm all right. I don't need to take any food with me. And then they go on till 2:30. And there, you know, you half feel like you're going to be unconscious on the floor after that. Modern insulins can bring a rapid change in blood sugar. One moment you're all right, and then you're not. And it, you know, I play golf, and over the course of a game of golf, it could change by about 15 units. So I might start, if I started out with my blood sugars reading 20, 15 units later, I'm down to 5, which is close enough to go in hypoglycemic, which is low blood sugar. Low blood sugar is no fun, really. You lose all sense of reality. Your capability of logical thought becomes dulled. You may think that I'm hypoglycemic at the moment, but it's quite difficult to. Needs to be avoided. If you're driving or anything like that, going hypo it's not the place where you want to be. In order to, you know, you need to be well controlled these days to maintain a driving license. If your GP says you're not fit to drive, then your license is revoked. And that can be through not looking after yourself with that, with diabetes. Diabetes is all a question of balance, really. If you eat loads of food, loads of carbohydrate in particular, or rapid high glycemic index carbohydrates, they just shove your blood sugar up out of control, and then you inject more insulin to bring it down, then you're going up again and then down again. You've got to try and keep a steady control. I like to make my own food, and then I know what's in it. I know there's no hidden sugars or whatever there that you buy from some takeaway meal or you know, something that's ready produced at the supermarkets. If you've made it yourself, you know what's in it. And I try to eat whole foods, like whole forms of carbohydrate, potato skins on, very nice, brown rice, brown bread, or wholemeal bread preferably, rather than white bread or white rice or whatever there, because that goes into your system quite a bit slower. So that makes you, gives you the ability to control yourself a little bit better. Let's say medical reviews are vital. You've got to attend those. You need to know where you are. The HbA1c is 3 monthly check on how your blood sugar's been over the last 3 months. Mine is currently 46, which is less than, you know, 42 to 47 is the range for someone who's pre-diabetic. So I think I'm doing reasonably well at controlling my diabetes. If it was 60 to 100, which some people have more difficulty than I do in controlling the diabetes, and they need further help. But I find with what I'm doing, must be doing something right, because I'm still here after all these years, and I feel okay on it. I have access to my records online, so I can always backtrack to see how I'm doing. At the moment, I was a bit of a surprise. My annual check, they checked my blood pressure, and it was higher than normal. But I blame that on being in lockdown. You normally play golf about 3 times a week or go walking in between. the golf's gone, so I'm still doing the walking, but still eating a bit more, bit of comfort eating, which I don't think it's me that's doing that. It's put a little bit of weight on. I've managed to lose half a stone in the last few weeks because I'm aware that my blood sugar is high. I think, well, the best way I can get that down is to lose a bit of weight. So I'm trying to take control of that. So healthy living is all about reducing your risk of the complication. We've heard all about the horrors that are in the future for people that don't take control. And I'm trying to avoid those. I hope everyone else who's living with it is doing so as well. So I've still managed to, okay, for 36 years. I've had a few difficulties, like Jupiter's contracture in both hands. Other problems which I don't want to share with you really here, but it's not without its side effects. But I've still managed to enjoy holidays. We've just booked another cruise before this meeting today. So if we ever get let out onto a boat again, we're in it next year. Don't ignore the rules. Look after yourself. Diabetes is going to change life. I'm a great supporter of this diabetes prevention program, and I've sat on the steering groups for it over the past 2.5 years. I've spoken to people who've been on it. If you're pre-diabetic, you're given the opportunity to not have diabetes rather than going on to develop the full form of it. I will grab that opportunity with both hands if it were me. I can't do anything about that. I can only look after myself because I've got type 1. But if I could reduce my risk of getting type 2 diabetes, then I'd do everything I could do with it. Thanks for listening, and good luck out there.
Thank you very much, Jeff. That was really informative, and brings us nicely to the fact, a reminder that more people have type 2 than have type 1. And so it gives me equal pleasure to introduce Mr. John Burnett, who is going to talk to us about living with type 2. And he knows well how to do that because he's done it for over 30 years. So over to you, John. Thank you very much.
Good afternoon, everybody. I'm John Burnett, and I'm a type 2 diabetic and have been so for 30 years. I was diagnosed 30 years ago. I went to my doctor on a Wellman clinic, and part of the routine was to have a blood test. 2 days later, a telephone call from the surgery. John, come in. You've got too much blood, too much sugar in your blood. And so they did some more tests, and I was diagnosed with diabetes. My reaction was one of surprise because I didn't have any of the classic symptoms of thirst, weight loss, tiredness, wanting to go to the loo. I wasn't obese. I played squash. I didn't smoke. I didn't drink an awful lot, so I was quite surprised. At that time, you were told it's a progressive disease or condition, and it will get worse as you go on. And all you can really do is slow it down. So if you do all the right things, I was told, you would slow it down. So I started off on diet, just controlling my diabetes on diet, and did that quite successfully for a number of years. But because it's progressive, I then started to go on to some medication. Metformin is the standard one for diabetics. So I was on metformin, and then gradually it got onto some other medication as well. And then about 4 or 5 years ago, it got to the point where I was advised by the diabetic nurses that really the best thing to do, John, would be to go onto insulin. So I was able to reduce some of my medication and go onto insulin, which I found suited me particularly well because I feel it's a more natural product as opposed to some of the chemicals I was on in the medication. And I certainly felt a lot better for it. So my current situation is, after 30 years, I'm 69 years old. I have a HbA1c, which is the blood sugar reading of 49. I've managed to bring that down over lockdown. I have a very good blood pressure, the blood pressure apparently of a 20-year-old, I'm told. So which 20-year-old, I'm not sure, but anyway, I've got the blood pressure of a 20-year-old. I've also got low cholesterol. My last eye check, the retinopathy check, I have no diabetic damage to my eyes. I have good kidney function, and I have good feeling in my feet and good pulses in my feet. So all in all, over 30 years, I have managed to control and slow down the progress of diabetes to an extent whereas I'm living extremely well. with diabetes, and I'm fit and I'm healthy, and it doesn't stop me doing all the things I want to do. So how do I cope with diabetes in my life? For a start, it's a state of mind. It's acceptance. If you're diagnosed with diabetes or pre-diabetes, please accept the fact that you've got it. A lot of people, when they're first diagnosed, go into denial. I haven't got it, or they're frightened by it. Diabetes is one of those things where sometimes you don't get any symptoms, and it's not like having a broken arm or whatever, or some diseases where you can really feel it. A lot of diabetics, you don't really feel any different. You just feel normal. And that can lull you into a very false sense of security. So as I say, accept you've got it, listen to what's being told to you by the experts, and if you can control your diabetes like Jeff does and I do, there's no reason you can't live a full life and do all the things you want to do. I have a saying, my philosophy is diabetes lives with me. I don't live with diabetes. So I'm in charge, not diabetes. So I know what I've got to do. I understand the complications and I know the consequences, but life is for living. So I do, I get on and I live my life. And the way I do that is I follow the medical advice that's given to me, and it's changing all the time. When I was first diagnosed, we didn't have these programs where you could put yourself into remission. You were told it's a progressive thing, it's going to get worse. You've got to try and slow it down and live with it. Whereas now it's different. So the understanding and technology is moving on. And so I also make sure I go for all my regular checkups. I never miss my checkups. I had one in January. It was into the see the nurse for one part, and then the telephone consultation second part. So I got my checks. Exercise and activity. A lot of people say, "Oh, increase your exercise." I prefer to use the word activity, because exercise thinks you've got to go to the gym, you've got to get on a bike, you've got to do this. Well, not everybody's capable of that. Activities such as going for walks, gardening, playing some of these sports like bowls. I play bowls and things like that. It's not particularly strenuous, but it's activity. You're up and you're about and there. The hardest thing you find being a diabetic is food. Food is by far the hardest thing to do, because obviously we're all reliant on food and we've all got to eat, but it's how does food react with my body? Carbohydrates, for instance, obviously turn into blood sugar. What fruits can I eat? What can I eat? What can't I eat? Reading the labels in supermarkets on food to see what the content is, so you know it's got a lot of hidden content in food. Quite often you'll see low-fat yogurt, and you think, wow, that's great, I'm on a diet, I'll have low-fat yogurt. But what do they put in into yogurt? Because they've taken the fat out, they put sugar in. So you've got to be very careful on that sort of thing. My weight's good. My BMI is 24, so I'm down below that. It's in that normal range, as opposed to the obese range. And as has been said earlier, nowadays they're giving you the tools to do the job, and it's all about self-management. More and more now, the onus is on you as a diabetic to manage the condition yourself. Take responsibility for it and self-manage it. Information, where do I go to get the information about how do I look after my diabetes? Well, you've been given a lot of information today, but beware, there's always a load of information out there, a lot of myths, a lot of people. Everyone's an expert in diabetes, as they are with everything. Even when they haven't got diabetes, they always think they know what they're all about it. In the papers every day, it's all about diabetes. I only go to two places to find out about diabetes information. One is the NHS websites, and the other one is Diabetes UK. Diabetes UK is an absolutely fantastic website. If you're struggling and you're diagnosed and you're in that stage where you've not got the help yet and you want to ask questions, go on to Diabetes UK. It's a fabulous website and they've got all the answers for you there. One thing you'll also maybe find about being a diabetic is it can be quite an isolating and lonely condition to live with. You feel you're the only one that's got it. Oh, nobody else has got diabetes, I'm the only one with diabetes. And this is where the mental thing comes in. So you need the support of, if you're lucky enough, you've got a wife, a husband, a partner, whatever, they can help you and support you. And certainly if you have a good support, that certainly helps you to manage your diabetes. You can also join groups. Diabetes UK have a network of peer support groups and community groups which you can join. And believe me, there is nothing like talking to another diabetic about being a diabetic. You can go to all your medical professionals and they can tell you all about, you should be doing this, you should be doing that, go on this course, go on that course. But believe me, talking to another diabetic who knows exactly what you're going through and how they're coping is, it's just as good as talking to a medical professional. And some of with these peer support groups and the support groups that there are around the country, when you all get together, you all realize you're in the same boat. And quite often, if you listen to another diabetic, what they're telling you can carry more weight than sometimes listening to a doctor, you know, or a nurse, because the person you're talking to is, they're living with it. And what you've got to remember about diabetes is not one size fits all. Everybody's different. What suits one person, the way they manage it, doesn't suit another person. What sort of food you eat may suit one person, but it doesn't suit another person. So really, at the end of the day, you know, it's a learning process. It's trial and error as you go along. Stick to the basic rules, but you can tweak them to suit yourself. Just a couple of, I've lived it for 30 years. I could talk all day. We could have programs and sessions all day about food and what to do. But just a couple of little tips I've picked up along the way. If you're going on a diet, you'll go into your supermarkets and everything, and you'll see all this stuff that says sugar-free. And you think, fantastic, I'll have this sugar-free stuff. Be very careful of sugar-free food. And you'll read on the back, quite a lot of the things they put in sugar-free has a laxative effect on your body. So if you do eat too much of it, you'll certainly be following two of the COVID rules. You'll certainly be staying at home, and you'll certainly be washing your hands a lot. So do not. It's all right to eat normal chocolate, and it's all right to eat ice cream. So, as I say, life is for living, and you know, you can eat. There's no food that is forbidden to a diabetic, but the foods that, like the treats, you don't have them every day. You eat them occasionally and a little bit. What I do, to be perfectly honest, if I like a little bit of ice cream, I'll eat it with a main meal. And if I've had Hannah from Desmond's, one of her wonderful meals, which is full of fruit and vegetable and fibre and one thing or another, if I eat my ice cream, that goes down into my tummy along with all the high fibre stuff, and the sugar in the ice cream is released more slowly than if I was to eat ice cream on an empty stomach, and it wouldn't spike my blood. So I wish you all the very best of luck. If you can get into remission, as Jeff says, get into remission. But if you follow the rules and you do everything you are told to do, you can live a full and healthy life. Thank you.
And thank you, John, and also to Jeff as well. Thank you, two gentlemen clearly living well with diabetes. Now, I'm reliably informed that we have lots of questions in our chat box. So first of all, I'm just going to say thank you very much to Leslie Watkins from Mansfield CVS, and also to Sarah Taylor from Ashfield Voluntary Action. Can't see Sarah at the moment, but she'll come up, I guess, in a minute, who've been coordinating this in the background, bringing the chat box to life for us. I'm now going to hand over to my colleague, Maria Di Giorgio, who's going to facilitate this section. Thank you very much, Maria.
Thank you, Jane. Thank you, everybody, for all of your questions. We've got quite a few, so if we can't answer them all, what we'll do is we'll get them answered and we'll add them into the chat box, add them into the toolkit that will be distributed or available to everybody after the event. So if I can invite Hannah to the mic, so Hannah from Desmond Diabetes Educators. Are you there, Hannah?
Yep, yeah.
Brilliant. Okay, so we've got a couple of questions for you. So the first one is, can I have salt in and on my food? And if not, how does it affect my diabetes type 2?
Yeah, so salt can increase our blood pressure. So salt can draw in fluid, increasing the overall volume, meaning that our heart's got to work harder to pump the blood around our body. So we do tend to have a lot of salt naturally added to the foods that we buy. So I guess that it's being careful sort of when you're looking at food labels. So when you're buying any processed foods, looking at the food labels, sort of comparing one product to the next to sort of see how much salt has been added to them. And then also, if you are adding salt, it's trying to practice to either think about adding it when you're cooking or at the table, or not, sort of not doing both there really. So thinking about doing one or another, and sort of gradually over time reducing your salt intake, and then your taste buds will get used to that really. And then sort of gradually they'll adapt, and sort of then when you do have anything with quite a high salt intake, you'll sort of really be able to taste that. So our taste buds do adapt over time as well.
Thank you, that's lovely. And I've got another question for you, if I may, Hannah. The question is, when you say managing weight, does that mean managing fat, or does it include muscle? So the person who's written this question says, I'm in good shape, but according to my BMI, I'm overweight.
BMI isn't always the sort of best indicator. I guess it's the best indicator that we have to be able to sort of put people into categories based on their weight really. But there's also other kind of considerations as well, like you say, with regards to muscle mass, etc. But waist measurement can be a really good indicator of kind of risk for type 2 diabetes in particular. So the Know Your Risk tool, does sort of use information around waist size or waist measurement, and that can sort of indicate your risk of developing type 2 diabetes. So sometimes it's also where people distribute their weight is the key thing, as well as, weight itself almost.
Lovely, thank you. And can I invite Diane to the mic, please? Diane Smith from Diabetes UK.
Hi.
Hi, Diane. I've got a question here for you that says, do you have a chat room where diabetics can connect?
Yeah, there is an online forum which can be accessed via our website. So if people want to go onto diabetes.org.uk, you'll see the links there to an online forum. You can just click onto that and you can chat with anybody else. There's hundreds and hundreds of people that join in there that talk about all sorts of things to do with diabetes, and I'd encourage people to do that because it's a really, really good way of people staying in touch, particularly during these difficult times of COVID where people can't get out to join other support groups, for example, face to face. But yes, there's an online forum that Diabetes UK run.
Thank you, that's lovely. And if I can invite Dr. Salis back to the mic.
Hello.
Hi, Dr. Salis. Some people have been talking about, or I've heard that some people talk about hypo. Can you explain what that is?
Hypo, are they writing, is it hypoglycemia? Just to make sure we talk about, okay. So hypoglycemia is the opposite of a diagnosis of diabetes. So it's a time when your blood sugar level drops. So we might have all, if you patients before they were diabetic, or even patients in the room who might not have diabetes. Sorry, I shouldn't have said patients. That's dropping into doctor wording. I do apologise. I'm getting tired. It's when you have the shakes. Do you know when you think, oh, I need some food? It's that you might feel a bit sweaty, maybe a bit irritable, dare I say, and you notice that when you eat something, it brings up your levels. Hypos, particularly that are related to diabetes, can sometimes be related to taking a medicine that drops you down. So, for example, if you take insulin and that doesn't, there's possibly a bit too much of the insulin, and the amount of insulin you're taking isn't quite right, it drops down your levels, because what happens is the insulin pulls it out of your bloodstream. There are other medications that are related to stimulating insulin, but essentially it's the principle of that blood sugar level dropping.
Okay, thank you. That's lovely. Thank you very much. That was really well explained. Can I ask John to step up to the mic, please? John Burnett?
Yeah, hello.
Okay, so I've got a question for you. You talked about support groups, and can you tell us what they do and how they support people, and how do people contact them?
I formed a support group about 2 years ago, and where we get together, like-minded diabetics, and in sessions we sort of break them down into two types of sessions. Quite often we'll have a guest speaker come along, like a diabetic specialist nurse One time we had a foot care specialist come along. We had a medical herbalist come along to talk to us about herbs in food and one thing and another. So we get experts along in their field to talk to us about managing diabetes. But quite often the best sessions we have is where we just really don't have anybody. We just sit and talk amongst ourselves, supporting each other emotionally and socially. And we're also passing on tips on living well with diabetes. And I always come away and I'm thinking, well, I know, I'll try that. Or you can pass on a tip to somebody else and they'll say, oh, I'll try that. So it's all about helping each other live with diabetes. And as I say, it can be a lonely existence, but when you get in amongst like-minded diabetics, you're all the same. You don't quite feel so alone. So it's a support. And really, as I say, Diabetes UK on their website, you can go and find where the groups are. But if there isn't one in your area, think about forming one.
Thank you. That's lovely. Thank you very much. Thank you, everybody, for answering the questions. We did have some questions come in that weren't answered, and some were already answered in the chat box. So what we'll do is we'll include them in the link, in the toolkit after the event so that everybody can access them. But right now, I'm going to hand you all over to Jane for our closing session. Thank you.
Thank you, Maria. Well, I can see that actually a lot of our numbers are dropping. We've had the question and answers. So if we can just move on to the next slide, I can explain those of you that are still on the meeting. We have got a closing poll just so that we can gain some idea of how much information we've been able to give you today. So on a scale of 1 to 5, where 1 is the lowest and 5 is the highest, can you please answer these 3 questions, ranking your level of knowledge of diabetes, managing diabetes, and support? You will have to answer all 3 questions before you can submit your answers. And I'm hoping that Maria's going to tell me how many people have answered that.
We're done on that.
We're done on that. Great. Great. Apologies, that was an opening poll. So can I just say that you actually were meant to get that at the beginning, but our technical hitches meant you didn't get it, but we're still going to use that as our information. And so if I could have the next slide, please, Maria.
Our closing poll?
No, oh, are we doing this one as well? Sorry, guys, You're going to do 2 polls. If you don't mind, again, on a scale of 1 to 5.
Nearly there.
Great. I can't see, so I'm depending on other people to tell me what's happening there.
We're nearly there. We're still going. We've got people answering. And I think we're done.
Great.
Okay.
So not much further to go. If I can have the next slide up, Maria, that would be lovely.
Oh, stuck on that one.
Not that one.
No,
next one. So that we can just say
we're just having a Benny.
It's quite all right. I'm going to remind you all that we have been recording the event. I can see that people have been writing loads, but you don't really need to, because we are going to be sending out a full toolkit after this event, and that will actually include the recording. It will also include, it's not going to include the closing poll, don't worry about that. It's going to include the recording, it's going to include all the presentations embedded into it, and it's also going to include, it's got loads and loads of resources provided by all the presenters. So really, all that's left is for me to say thank you. And I don't know how I'm managing to do this without slides, but it doesn't matter. It's really just to say, oh yes, sorry, I should be reminded, also an evaluation. You are going to get a survey so that we can find out if you enjoyed the event. It will provide you with the opportunity to extend the contact with us if you think you would like to get more information about follow-up, and even our newsletter, which we send out regularly. And really, there at the bottom, again, you don't need to make a note of this, but there's an email that will take you directly to us in order that you can get some more information. Thank you. And this brings me to that last slide, in which I'm going to say thank you, and that really is quite simply, it's thank you to the presenters for their considerable time in helping to plan and deliver today's event. Thank you to the technical fairies that have made it happen in the background, to Maria, to Leslie, to Sarah, and to Emily, our IT coordinator. And best of all, our most patient audience. Thank you for bearing with us when we have those little blips at the beginning and sticking with us. So thank you very much. I hope you have found it an enjoyable day, and I hope you'll all come again when we have the next event. So we want loads of ideas of what you'd like for the next topic. Thank you very much. That's all I've got to say.